Welcome to the deep dive. Today we're looking into something quite common: varicose veins. Specifically, we're comparing two treatments.
That's right. We're focusing on radiofrequency ablation, RFA, and endovenous laser therapy, EVLT.
And we're basing this on a particular study, aren't we? A head-to-head comparison.
We are. It's a study from the Annals of Surgery, published back in 2011. It's titled A Prospective Double-Blind Randomized Controlled Trial of Radiofrequency versus Laser Treatment of the Great Saphenous Vein in Patients with Varicose Veins. Quite a mouthful, but important.
Definitely. So if you're dealing with varicose veins yourself, or maybe you're just curious about how medical treatments get compared, this deep dive should be really interesting for you.
Our goal here is really to unpack what this specific study found. What did the science show when comparing RFA and EVLT side by side, at least back then?
Okay, so before these techniques, RFA and EVLT, what was the standard approach? Was it just surgery?
Pretty much. For significant issues with the great saphenous vein, traditional open surgery vein stripping was the main option. These newer endovenous methods came along as much less invasive alternatives.
Right, less invasive usually means quicker recovery, which is always appealing.
Exactly. But when they first became popular, there wasn't, a lot of really solid evidence comparing RFA directly with EVLT. People were using both, but we needed that direct comparison.
Which is where this 2011 study comes in.
Precisely. It was designed to fill that gap, to provide a rigorous head-to-head look at how well they worked and, importantly, what the patient experience was like for each.
And you mentioned rigorous. This study design sounds pretty robust.
Oh, absolutely. It was a prospective, double-blind, randomized controlled trial that's often seen as the gold standard for clinical research.
Can you break that down a bit? Prospective, double-blind, RCT.
Sure. Prospective means they decided what to study and then followed patients forward in time. Randomized controlled trial, or RCT, means patients were randomly assigned to get either RFA or EVLT, which helps ensure the groups are comparable.
Okay, and double-blind.
That means neither the patients participating nor the researchers assessing the outcomes knew which treatment the patient received. It helps prevent bias and, reporting pain or evaluating results.
That definitely sounds like a solid setup. So who were the patients in this trial?
They recruited adults aged 18 to 80. The key thing was they had to have primary varicose veins, meaning not caused by another condition like DVT that were symptomatic, specifically related to the great saphenous vein.
Symptomatic meaning they were causing problems like pain or aching.
Yes. And they also needed a CEP classification grade over 2, which basically indicates more visually obvious or troublesome varicose veins, not just tiny spider veins.
Were there people they specifically excluded?
Yes, quite a few. Things like pregnancy, having had previous treatment on that vein, a history of blood clots like DVT or PE, being on blood thinners, needing specific kinds of pain control, or having problems in other major veins. They wanted a fairly specific group.
Got it. So, focused on a particular type of varicose vein patient, what about the procedures themselves in the study? How are they done?
Interestingly, both groups had their procedure under general anesthesia.
Oh, really? Is that still common?
Not so much anymore. The authors even mentioned this as a limitation later on. Now, these are very commonly done with just local anesthesia, maybe some light sedation, often right in the doctor's office.
Okay, good context. What else was standard?
Both groups got standardized pain management after the procedure. And importantly, they also performed phlebectomy at the same time for both groups.
Phlebectomy, that's removing the smaller, visible, lumpy veins.
Exactly. Through tiny little punctures or incisions. So everyone got the main vein treated and the surface veins tidied up, so to speak.
Makes sense. Now, the core difference, the RFA versus the EVLT, how did they work in this study?
Okay, so for RFA, they used a system called VNUS Closure Fast. It involves a catheter that delivers radiofrequency energy in segments. It heats the vein wall to about 120 degrees Celsius, causing it to shrink and close.
Segmental heating.
Right. They treated the vein in 7-centimeter segments, pulling the catheter back each time. They specifically did a double treatment on the very top part of the vein and used compression on the outside. The target power was kept under 20 watts.
Okay. And the EVLT?
For EVLT, they used an 810 nanometer diode laser. This involves inserting a laser fiber, and instead of segmental treatment, it's a continuous pullback.
Ah, okay.
Yeah, they withdrew the fiber continuously at 2 millimeters per second, delivering 12 watts of power. The goal was an energy delivery of about 80 joules per centimeter of vein treated. So continuous laser energy instead of pulsed radiofrequency energy.
Different ways of delivering heat, essentially.
That's the core idea. And the researchers checked carefully to make sure the groups were similar. Otherwise, age, vein size, how severe the disease was, procedure time, amount of numbing fluid used, all very well matched.
Even pre-op quality of life scores were similar.
Yes, they started from a very similar baseline, which is crucial for a fair comparison.
All right, the setup is clear. Let's get to the results. The big question. Did one work better than the other at actually closing the vein?
This was the primary outcome they looked at: vein occlusion at 3 months. But first, the 1-week results were, well, perfect.
Perfect.
100% occlusion rate in both groups at 1 week, confirmed by ultrasound. The treated vein was closed in every single patient checked.
Wow, okay. You can't beat 100%. Did that hold up at the 3-month mark?
Pretty much. Really excellent results continued. At 3 months, the RFA group had a 97% occlusion rate, and the EVLT group had 96%.
97 versus 96%, so basically the same.
Exactly. Statistically, there was no significant difference between them. P 0.67, for those interested. The bottom line from this study on effectiveness alone was that both RFA and EVLT were highly successful at closing the great saphenous vein in the short term.
That's a really key finding. Both do the job well, but effectiveness isn't the whole story, right? What about the patient's experience, pain, recovery, that sort of thing?
Right, and that's where some differences did emerge in this study. They looked at several secondary outcomes. Pain was a big one.
What did they find regarding pain?
Patients in the RFA group reported significantly less postoperative pain compared to the EVLT group. This was consistent at day 1, day 3, and day 7 after the procedure.
How significant are we talking?
Well, for example, on day 1, the median pain score on a scale they used was 28 for the EVLT group, but only 9.5 for the RFA group. It's quite a noticeable difference in discomfort early on.
Yeah, that sounds like something patients would definitely care about. Less pain is always better. What about bruising? Was there a difference there too?
There was. The EVLT group had significantly more bruising at the 1-week mark. They measured the percentage of the thigh area above the knee that was bruised.
Okay.
The median was 3.85% for EVLT, compared to just 0.6% for RFA. So noticeably less black and blue with RFA in this trial.
Less pain, less bruising. Starting to sound like RFA had the edge on the immediate recovery experience in this study. Did that translate to needing less pain medicine?
The study didn't explicitly report the amount of pain meds used, but given the significantly lower pain scores in the RFA group, it's a pretty strong implication that they likely needed less pain relief.
Makes sense. Were there any safety concerns, any difference in complications?
Thankfully, serious complications were rare overall. There was about a 2% incidence of minor things like small skin burns, some temporary numbness or tingling called paresthesia, or superficial vein inflammation, thrombophlebitis. But this rate was similar in both groups.
And no major issues like blood clots?
No DVTs or PEs reported in either group, which is very reassuring.
Okay, good. What about getting back to normal life? Return to work?
They did track return to work. Interestingly, the median time was slightly shorter for the EVLT group, 7 days, compared to 9 days for RFA.
So EVLT was slightly faster there.
Numerically, yes, but the difference wasn't statistically significant. So the researchers concluded there wasn't really a meaningful difference in return to work time between the two based on this data. Kind of a wash.
Okay. And the overall quality of life impact, did one lead to better long-term well-being?
At the 3-month follow-up, both treatments showed similar improvements in quality of life. They used specific varicose vein questionnaires, like the EVVQ, and general health questionnaires, like the EQ5D. Both groups felt significantly better than before treatment, and to a similar degree.
So summarizing the patient experience side, RFA seemed to mean less pain and bruising right after, but return to work and overall quality of life improvements at 3 months were pretty similar for both in this study.
That's a good summary of those findings, yes.
Now, how did the study authors reflect on their own work? Did they point out strengths and weaknesses?
They definitely highlighted the strength of it being an independent, double-blind RCT, that robust design we talked about. But they were also upfront about limitations.
Like what?
Well, one was patient follow-up. They lost some patients along the way, which is common, but always a limitation to note. Another, as we mentioned, was the use of general anesthesia.
Right, because that's not standard practice now.
Exactly. Procedures under local anesthesia might have different pain profiles or recovery experiences. And finally, they acknowledged they only compared RFA and this specific type of EVLT. There are other treatments out there, like newer laser types, foam sclerotherapy, mechanochemical ablation, or MOCA.
So it was a snapshot comparing two specific options at a specific time with a specific anesthetic technique.
Precisely. A valuable snapshot, but still a snapshot.
Okay, so this was published in 2011. What kind of splash did it make then, and how does it sit within the field today, over a decade later?
At the time, it was quite impactful. It was really the first high-quality trial of its kind, independent, double-blind, showing these important patient-centered differences, especially the lower pain and bruising with RFA.
So the takeaway then was maybe leaning towards RFA for a smoother, immediate recovery.
That was certainly a key message derived from this study, yes. While both were effective, the better early experience with RFA was a significant finding for patient comfort and potentially getting back to activities faster, even if return-to-work stats weren't significantly different.
But things change fast in medicine. How has the field evolved since 2011?
Quite significantly.
Yeah.
The move to office-based procedures under local anesthesia is probably the biggest shift in practice. Technology-wise, laser has evolved a lot. Newer wavelengths, like 1470mm lasers, are now very common. Some studies suggest these newer lasers might have different profiles, potentially even closing the gap, or some argue maybe performing better than RFA in certain ways now.
And RFA tech hasn't stood still either, I assume.
No, RFA systems have also been refined. The VNUS system, for example, which evolved from the Closure Fast used in the study, aimed for even more precise temperature control. So both technologies have advanced.
Has other research come out since then that adds to the picture?
Oh, definitely. There have been numerous studies. For instance, the CLASS trial in the UK compared surgery, foam, EVLT, and RFA, finding thermal ablation techniques like EVLT and RFA generally more effective and cost-effective than foam or surgery long-term.
Interesting. Any others?
Other studies have compared thermal ablation, RFA, EVLT, to non-thermal methods like Embellier, often finding RFA and EVLT might have better closure rates at, say, the 1-year mark.
Yeah.
And another important trial, the EVRA study, showed that treating the underlying vein issue early with endovenous ablation helps heal venous leg ulcers much faster.
So the evidence base keeps growing and getting more nuanced.
Absolutely. And the consistent theme is that treating significant varicose veins generally leads to substantial quality of life improvements and is considered cost-effective for healthcare systems.
It really sounds like while this 2011 study was a landmark piece providing crucial early comparative data, the ongoing evolution of both RFA and EVLT makes it hard to just point to this one study now and declare a definitive winner for all situations.
That's exactly right. It provided invaluable insights, particularly regarding the patient experience with the technologies of that time. But the field keeps moving. Declaring one definitively superior across the board today is challenging.
Okay, let's try to pull the threads together then. What are the key takeaways for someone listening to this deep dive?
Well, the core finding from this specific 2011 research was clear. Both RFA and EVLT, using the technologies available then, were very effective at closing the main superficial vein, the GSV. High success rates for both.
But with a difference in the immediate aftermath.
Yes. In this study, conducted under general anesthesia, RFA resulted in significantly less pain and less bruising in the first week compared to the 810mm EVLT used.
Crucially, though, things have changed since then.
Hugely important point. We can't just extrapolate these findings directly to today's practice without considering the shift to local anesthesia and the advancements in both RFA and especially laser technology with newer wavelengths.
So for you, the listener, perhaps thinking about treatment options, what should you consider based on this?
It highlights that there's more to consider than just, does it close the vein? The experience matters: pain, bruising, recovery time. This study showed those could differ. So thinking about what's most important to you personally is key.
Like how much does short-term discomfort bother you versus maybe other factors?
Exactly. Are you more concerned about minimizing pain in the first few days? How quickly do you absolutely need to be back to strenuous activity? What specific types of RFA or laser are available where you are? These are all things to discuss.
So this deep dive gives a solid grounding in some of the historical evidence, but it's really a starting point for a conversation with your own doctor.
Absolutely. It provides context, shows the kinds of questions researchers ask, but your individual situation and the current available options are what guide the final decision made together with your healthcare provider.
Right. And it leaves us with a fascinating thought, doesn't it? Given how much RFA and EVLT have already evolved since 2011, How may future studies comparing the latest versions of these technologies, or perhaps entirely new approaches we haven't even discussed, redefine what the best treatment looks like 5 or 10 years from now? What's the next big thing going to be in varicose vein care?
That's the exciting part about medicine, isn't it? Constant evolution. It will be interesting to see.
Indeed. Thanks for joining us for this deep dive.